Good evening, and welcome to Doctors on Call. Tonight, we're talking about eye problems like cataracts, glaucoma, macular degeneration. I'm your host, Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School here in Duluth. And I'm pleased to welcome tonight's panelists and guests, Dr. Charlie Ahrens, an ophthalmologist with St. Luke's Miller Creek Center in Hermantown, Dr. Lisa Graham, an ophthalmologist with Relf EyeCare Specialists in Hermantown, and Dr. Joseph Morehouse, an ophthalmologist with Essentia Health, Duluth Clinic. We'll be happy to take your questions about eye problems. Just give us a call locally at 218-788-2844 or toll free at 1-877-307-8762. Our medical students answering the phones tonight are all from Minnesota. Grant Carlisle is from Grand Rapids, Tyler Kunst is from Belle Plaine, and Shrikar Rajgopal is from La Crescent, Minnesota. And now on to tonight's program. Dr. Ahrens, I've kind of changed things a little bit as we start out. I'd kind of like to know a little bit more about the panelists than me just reading off the names.
Okay.
And I'd like to ask each of you if you could just talk a little bit about yourself, where you're practicing, a little bit about your education, what you're interested in ophthalmology.
Okay. Well, my practice is in Hermantown at St. Luke's Miller Creek Medical Clinic. And I also do outreach in Hibbing Medical Clinic up there. My background is I went to school here in Scholastica for my 4 years of undergrad, and then I went to the University of South Dakota down in Vermilion for my medical school, and went to the Beaumont Health System in Royal Oak, Michigan for my residency training. My practice is I'm a general ophthalmologist, and I do most things with ophthalmology, including cataracts, refractive surgery like LASIK, PRK, glaucoma treatment, oculoplastics, and medical retina, including injections for macular degeneration.
Great, thank you. Dr. Graham.
Well, I started out undergrad, University of Tennessee in Knoxville. Medical school was in Medical University of South Carolina in Charleston, South Carolina. I did some time in the Navy as a flight surgeon, and then I did my ophthalmology training in Indianapolis. And I've been a private practice comprehensive ophthalmologist for, 17 years now. And I've been in Duluth for going on 9 years. And before that in Wisconsin, I practiced comprehensive ophthalmology there as well. And like Dr. Ahrens, I do a little bit of everything. A lot of cataracts, a lot of glaucoma, medical retina, macular degeneration, plastic surgery, a little pediatric ophthalmology, just a bit, and then refractive surgery as well.
Thank you for your service contributions.
And happy birthday to the Marine Corps today, and happy Veterans Day tomorrow.
Yes. Dr. Morehouse.
I did my undergraduate degree at Creighton University in Omaha, and went on to medical school at Georgetown University. Then I too was in the service. I was in the United States Air Force, serving as a flight surgeon in the Tampa, Florida area, and then went on to residency in the Air Force program at Wilford Hall in San Antonio. Practiced for a couple years in the Air Force up in Alaska, and then moved here nearly 17 years ago. And I currently practice at Essentia Health, both downtown Duluth and in our Superior location. And I'm a comprehensive or a general ophthalmologist as well. Cataract surgery is probably the biggest surgical thing I do, glaucoma surgeries, various lasers, and that pretty much covers it.
Great, and thank you for your service also. You were kind enough to bring this model tonight, so do you want to talk a little bit about the anatomy of the eye, just to start us off?
I'd be happy to. So just to orient everyone, obviously this is the front of the eye. The first thing that you see here is the cornea, which is, you can think of it almost like the windshield of the eye or the watch crystal of the eye. The white of the eye is called the sclera. It's a tough connective tissue covering of the outside of the eye. The sclera is actually covered by another layer called the conjunctiva. When you get pink eye, that's basically an inflammation of the conjunctiva. Inside the eye, the colored part of the eye is the iris. And of course, the hole in the iris that looks black when we look at someone's eye is the pupil. Behind the pupil sits the lens. And then the retina is the visual organ of the eye, if you will. It's almost like if the eye was a camera, the retina would be the film of the camera. And then this space in here is filled with a jelly that's clear called the vitreous. And then you can see the optic nerve heading back toward the brain. That's how the eye is connected to the brain, and the visual information goes to the brain.
Very good, thank you. Any additions?
That covers it.
You got it.
Well done. Lisa, I'd like to just kind of move to the outside of the eye just a little bit, and maybe it's this time of year, and I'm a family doc, and we see a lot of the same things you do probably, and struggle with some of these things too. The dry eye complaint.
Gosh, dry eye is a ubiquitous complaint. So many people have dry eyes. It's always worse in the winter, which is obviously the season we're up against, because the air is drier, less humidity. Our eyes make tears and they drain tears. Good tears are required to lubricate the surface of the eye, keep the eye comfortable. The cornea, the clear window on the front of your eye, it has to have a nice slick of tears over it for you to see clearly. If the tear film breaks up or is insufficient, vision will be blurry. And that's a complaint that kind of comes and goes often, especially with visual tasks in folks who have dry eye. So if they're reading, they'll say, oh gosh, I can read for 10 minutes and then my vision gets blurry. That's almost always dry eye. And people can use artificial tears that are available over the counter to help lubricate their eyes. They can do warm compresses to get the oils flowing. Some supplements such as fish oil or omega-3 supplements can help with dry eye. There are some prescription medications that can help, a variety of things.
The tearing that happens from the dry eye, is that a little different tearing than the normal tearing?
Yeah, our eyes, whenever our eyes are irritated, they tear. And it can be for almost any reason, allergies, but dry eye is one of the most common reasons. So eyes dry out, and then the brain says, make tears, and then they flood and drip. And people confuse it because they say, well, how can my eyes be dry if they're dripping? But they can be.
Thank you. Dr. Ahrens, I'm going to stay on the outside of the eye before we take a dive
Sure.
to the inside. Let's talk just a little bit about blepharitis, if you will.
Okay. Much like dry eyes, with blepharitis, we have inflammation of the eyelids themselves, and it's a really common, really common diagnosis that I make, every day at several, if not even tens of times a day. And it all has to do with the environment of the tear film, just like Lisa was saying, in that you need a good, healthy tear film. And when the eyelids get inflamed, they stop producing the oils that we need to protect the tears from evaporating off. The oil becomes irregular. We start having irritation, itching, burning. A lot of times you'll see this, especially when patients are waking up in the morning and they say, boy, I'm really itching, irritating. I've got gunk in my eyes that I can't get out. And all this is tied in with dry eyes as well as part of the whole environmental and inflammatory condition that we have. And just like Lisa and yourself had said, I see this more nowadays as the weather's getting colder. And so a lot of times when I'm treating patients and they have these symptoms, I'm treating them both for blepharitis and dry eyes to try and attack both areas at the same time to help their symptoms.
Thank you very much. We'll move into the eye. Lisa, cataracts, is this getting more frequent than it's been in the past? It seems like more and more people are having cataracts and more cataract surgery. Maybe I'm taking care of an older population.
That could be.
And is there anything, any of you, are there things that we can do to keep this from happening? Just some discussion and lead us off, if you will.
Well, I hate to say it, but cataracts are pretty inevitable. They're just an aging process. So pretty much everybody gets cataract. Most people have some by age 60, and we say everybody has some by age 70. There's a lot of factors involved with how quickly they progress. However, certain diseases will cause cataracts to happen at a younger age. Diabetes is the main one. I think genetics play a role. Certain families tend to get cataracts at a younger age, it seems. I think just a good, healthy lifestyle, eating right, trying to be healthy, does perhaps slow the progression. Sunlight probably plays a role in cataract formation. Folks exposed to more sunlight or lacking sunlight protection might get them more quickly. but they're so multifactorial, it's really hard to say. So I think that we're stuck with cataracts. I think we're doing cataract surgery at a younger age, however, so that might be why you're seeing more of them, because the cataract surgery is safer than it's ever been, so there's less risk, so you will do it at an earlier stage than we used to when there were more risks.
Okay, Joe, show us what we're going to do and what happens with cataracts, if you will, a little bit.
Okay, so
And you guys can jump in any time on this one.
So the definition of a cataract is a cloudy lens. So, and everybody's, as Dr. Graham said, basically somewhere in our 40s, 50s, or 60s, our lenses turn from crystal clear into kind of yellowish, and then they become slowly cloudy. Once you get to a point where the cataracts are what we call visually significant, or basically interfering with your lifestyle, the only way to fix a cataract is to basically remove it. So when we talk about cataract surgery, that just means basically taking out the cloudy lens from the eye, and we actually, in this day and age, we replace that cloudy lens, the focusing power that lens gives us, with a man-made clear plastic lens.
Charlie, as long as we have this up, don't put it down yet.
Okay.
So glaucoma.
Yes.
Does cataracts, tell me first of all, what is glaucoma?
Well, glaucoma is kind of a complex disease, but basically glaucoma is damage to the optic nerve. Okay, and so the fibers that run from the retina to the optic nerve, when those nerve fibers start to die off for multiple different reasons, that is glaucoma. And in what we call primary open angle glaucoma, or general glaucoma that everyone thinks of, we think that one of the biggest risk factors is elevated pressure inside the eye. And there are also other multiple risk factors based on all of our major studies, but the one that we can treat, or the only modifiable risk factor that we have, is pressure inside the eye. So that's why when we're talking about glaucoma, and when family members are talking about glaucoma, they always say, well, it's because of the pressure on the eye. And well, yes, that's the risk factor, and that's how we treat it, so that's how it's relatable. It's actually damage to the optic nerve and that neurologic pathway that Joe was talking about to transmit the light signals back to the brain.
So the reason for the question is that the caller had put the two together,
Yes,
cataracts
very
and
common.
glaucoma. Do one of you want to address that situation? Does cataract surgery help with glaucoma? Does it make it worse? Does it cause glaucoma? Lisa, if you want to chime in.
It does not cause glaucoma. Sometimes pressures around the time of cataract surgery can be higher or lower. We typically do see a few points lower pressure after routine cataract surgery. So somebody who has glaucoma, simply having cataract surgery could help their pressure a little bit. And it's more in the news because there's a lot of new devices on the market that are FDA approved, that are little implantable devices at the time of cataract surgery that can actually help lower the eye pressure and provide better control of glaucoma as well. And people are excited about that because it's a way to get off of eye drops, or maybe minimize your eye drops a bit.
Very good. Joe, as long as you still have the eye.
I got a feeling I'm not going to get to put it down.
Well, we'll let you do it in a minute. So macular degeneration, can you show us on the eye where that problem occurs?
Absolutely. So the term macular degeneration comes from is based on the macula is basically Latin for spot, and the macula of the retina is the central part of the retina where all our crisp 20/20 vision lives. And macular degeneration is basically caused by an accumulation of metabolic byproducts that basically form what we call drusen within the retina that kind of causes disturbance or degeneration of the photoreceptors.
So how do you make the diagnosis of macular degeneration? Charlie?
Usually it's with our clinical exam, and like Joe was saying, we see drusen, and what drusen are, what we're looking at, when we see the very early stages, we're looking at the back of the retina, just through our lenses and things, and we see little tiny white spots, or we see little pigmentary changes within the retina, little areas that signify, well, maybe there's some dying off of those retina cells, and those are the early signs. We're also looking at the vision that the patient is noting. Are they having distortion in their vision? Things like that, where we might say, okay, is now, instead of just the standard dry macular degeneration, is there wet macular degeneration changes, where you have now fluid leaking into the back of the retina, blood leaking into the back of the retina, scarring, things like that.
Are there, Lisa, are there any ways to avoid this problem, macular degeneration? Is it genetic, or can you give us a little background?
It's multifactorial. There is definitely a genetic component, and there's a lot of interesting research going on about genetic markers, and which hopefully will lead to new ways to treat macular degeneration from that perspective. But it's also nutritional and environmental and just related to your general health. I think nutrition plays a big role, and in fact, modifying your nutrition is about the only way to slow down the progression of macular degeneration as it stands today. So we recommend, my typical talk, I say it 100 times a day, is eat your green leafy vegetables, which includes broccoli, kale, and spinach. Eat your bright red, orange, yellow vegetables, and not just carrots. Got to eat squash, pumpkin, sweet potatoes, all those good
Dark chocolate?
Dark chocolate is not on that list, but yes, it has some redeeming qualities. So antioxidants are good for the retina. They help with that metabolism that Joe was talking about, where the metabolic byproducts accumulate in the retina. And if you have these antioxidant nutrients on board, you may get less of those byproducts in the retina.
There's a couple of things. One is maybe talk about the fact that people really don't ever go blind from this, but the problem it has. And then the other question that comes up, is there a timeline? And you can, Joe, you haven't, we've been making you hold the
There you go.
eyeballs, so if you want to do something.
Actually, I was going to, what I tell my patients about the risk factors is that the modifiable risk factors for macular degeneration pretty much parallel those for heart disease. So smoking is a risk factor, high cholesterol is a risk factor, body mass index is a risk factor for macular degeneration, as is hypertension. So basically do what your family practice physician tells you to do to modify your heart factors, and you've probably done a lot of what you can do to modify your macular degeneration risk factors. Now let's see, remind me of what your question was again, Ray.
That might have been it.
Okay.
I'm just going to switch a little bit because we're getting a lot of questions on floaters. So what are they? Charlie, it's back to your end, so we'll let you go.
We were actually just talking about this before back in the break room. This is, when we are on call, this is probably the #1 medical question that we get from people calling in, is I have new floaters. And what this is, it is a little bit of an aging process in that as we age, the gel in the back of the eye, like Joe had pointed out, as we age, that gel starts to liquefy, and as it liquefies, it forms little lakes and pools inside that mass of the gel. And so as we're moving our eyes around back and forth, it can move around and fluctuate as well, and it can actually separate off of the retina and off of the optic nerve where it's densely adherent. When it separates off, now instead of looking through a clear stretch out sheet of cellophane, it separates off, kind of crinkles up, and it floats back and forth, and that's what you're seeing as the floaters. And why that's important to know and to contact us is because when that separates off, it can actually tear the retina. If it tears the retina, the fluid that's in the back of the eye can then lift the retina off, causing a detachment, and that's obviously bad news for vision if that happens.
So the rest of that question was, are the doctors in the area able to do something about floaters? So, Lisa?
I tell most of my patients, try to live with your floaters. They're a normal aging process. Yes, they are annoying, but most people can learn to ignore them just fine. If you have had bleeding in your eye or a retina problem where you have very dense floaters, they can be removed surgically. But for routine floaters, that surgery is probably too risky for what it's worth. There's a new laser out there that can break up floaters, but I've kind of heard pros and cons and perhaps maybe too many complications from it. That I'm not ready to adopt that technology yet, but there is a laser being advertised for that.
And we, not to jump in, well,
go ahead.
I'm going to jump in. We actually at Essentia, we do have that laser, and it does. There are there's a subset of people with floaters who can benefit from having the laser. Usually, I'll wait until they've had their floaters for several months, maybe 6 months, and it's it's not a perfect solution, but a lot of times it can at least reduce symptoms for people that are really bothered by them.
As long as we're back and talking about the back of the eye, there's other discussion also about the retina coming loose or separation of the retina. and putting a lot of things in here, secondary cataracts and things like this. So now we're getting into the laser business just a little bit. So if you want to just talk a little bit more, as long as you're at this.
So, well, that's kind of a broad question.
is.
Let's see, secondary cataracts refer to when we take out a cataract, we actually leave the lens that we remove actually has almost like a shrink wrap coating to it, and we save the back part of that shrink wrap coating, which is the way that we support the new lens. In many cases, that shrink wrap turns into more like wax paper. So it gets cloudy over time because there's always a few cells from the original lens left over after cataract surgery, and those cells can make that membrane cloudy. And so the term secondary cataract kind of refers to a cloudy membrane, and the treatment for that is basically to take a laser and poke a little hole in that membrane.
Okay. There was a broad question, so one of the others, if you want to jump in on some of the things we were.
Oh gosh, we use lasers for a lot of things, so it can be very confusing.
You do this in the office?
In the office or a surgical center, yes. The laser that we use for the secondary cataract has been modified for a glaucoma procedure that can help the eye filter more fluid out more readily, and that can help with pressure management. I do that laser very commonly for my glaucoma patients. We use lasers for refractive surgery, for LASIK and PRK.
We also use a significant amount of lasers for retina treatments as well. So as we were talking about the retina tears and the detachments, we'll use, if we see only a small tear and no significant detachment, we'll use a laser to kind of try and barricade that tear in to prevent a detachment from happening. Also for our diabetics who have issues with diabetic retinopathy and certain types of that, including swelling on the retina, if we have vein occlusions, retinal artery occlusions, things where we have swelling overlying from those, we'll also use a different type of laser than what Joe and Lisa have been describing to treat those types of diseases.
Joe, the question that I started before that we didn't finish, is there a timeline for macular degeneration?
It's quite variable, really. Typically, macular degeneration, probably for most people, it doesn't, probably the majority of people that have macular degeneration don't lose very much, if any, vision at all. And then so macular degeneration kind of starts out as what we call the dry kind, which means no fluid under the retina. In the wet kind, vision loss can be relatively more profound and occur more rapidly. And that basically refers to kind of leaking blood vessels underneath the retina that can cause a much more rapid loss of vision. So in short, it's quite variable, I'd say.
Lisa, go ahead.
And the thing that you sort of alluded to before, which I think is very reassuring to a lot of patients, is that macular degeneration can steal the vision within the macula, which is your center of vision, but it almost never affects your peripheral vision. And that can be very reassuring. So yes, you may have very poor vision from advanced macular degeneration, but you'll probably never be totally blind. You'll have what we call getting around vision. And that is comforting to a lot of folks.
Yep. And the Lighthouse for the Blind and others help a lot with that, so that's great.
Yeah.
As long as you're the pediatric ophthalmologist.
No, go that far.
Don't run away yet. Can a blocked tear duct in an infant lead to complications?
Yes.
6 months old.
Yes. The good news, though, is that most blocked tear ducts in infants spontaneously resolve. Upwards to 80% of them, maybe even 90 by about 18 months of age. So you sort of have to be patient. But any fluid that sits still in an enclosed space can get infected. So tears sitting in that canal that can't flow all the way through can become an infection. So if you're seeing a really mattery eye and redness and swelling, then it should be treated usually just with eye drops or an ointment, because repeated infections will scar the canal even more.
Charlie, what's the normal range of pressure in an eye?
Usually,
kind of a loaded question, but.
Well, I mean, usually I just tell patients, because it's easy to remember, it's probably about 10 to 20. I'm sure there's other studies out there that might vary a couple degrees, but it's easy to remember 10 to 20. And it's important to remember, especially when you come and visit us, that if I tell you your pressure is 23, which is above the normal range, it doesn't necessarily mean that you have glaucoma. And just because I tell you your pressure is 15, it doesn't mean that you don't have glaucoma, because we're still talking about normalized numbers here and giant bell curves and population-based issues there. So while yes, we use that as a guideline and those are our risk factors, 10 to 20 is the normal. Outside that, we're still watching for these other things that can be risks.
Panel, thank you very much. We have a whole load of questions that we didn't get to. Great discussion. I want to thank our panelists, Dr. Charles Ahrens, Dr. Lisa Graham, and Dr. Joseph Morehouse, and our medical student volunteers, Grant Carlisle, Tyler Kunst, and Shrika Rajagopal, and for their work and help tonight. Please join Dr. Ruth Westra next week for a program on upper GI problems when her panelists will be Dr. Robert Erickson, Dr. Mary Owen, and Dr. Chris Thiessen. Thank you very much for watching, and good night.